Good morning, everyone. I am happy to see everyone putting their attendance in the chat box. Thank you, and please continue to do so to record your attendance this morning. We have reached week 10, pharmacotherapy for obesity. I'll remind you to keep yourself on mute unless you're speaking, and I think we can go around the room here and introduce ourselves. I'm Shannon Switkowski, the clinic coordinator.
Jesse Lewis, program manager.
And I'm Rick Fernaccio, web content producer.
Okay, and Dr. Rao is joining us remotely, and I'll let him go ahead and introduce himself. Jim Werner is also remotely as well. Chris Taylor is here. And go ahead, Dr. Rao.
Good morning, everyone. This is Goutham Rao. I'm the director of the ECHO series.
Yeah, this is Jim Werner, Case Western Reserve University behaviorist.
Sorry, I wasn't able to be at the ECHO Hub today. When they devise a transport system like they had on Star Trek, I'll be able to get from place to place in 1 minute, but not today. So we have reached week 10, as Shannon said, and this is more of a practical sort of session didactic on pharmacotherapy, which I know a lot of people have been asking about. I want you to keep in mind an important principle, however, and the choice of pharmacotherapy is less important than the decision as to when to initiate it and the types of patients in which to initiate it. I'm going to go through briefly the available therapeutic options. That is less important because, as we'll talk about, the choice is not so determined by effectiveness, et cetera, but rather practical issues like insurance and side effects. So move to the next slide, please. Okay, these are our disclosures. I am going to use a quote from a book I wrote in 2006, which is a popular book for parents, published by Penguin Random House, but not advocating buying it. It's old, and it just illustrates a certain point. And the remaining disclosures you can see from Adam, Siran, and Chris as well. Next slide. So pharmacotherapy for obesity, and as I said, keep that principle in mind. The choice of medication is less important than the patient and the circumstances in which you prescribe it. Next slide, please. So here's some basic objectives. I want you to be able to define satiety and satiation. These are two important terms because most medications work either through one or both of these mechanisms predominantly, and they're very, very different things. List and describe a minimum of 3 pharmacotherapeutic options for weight loss and describe a minimum of 3 situations in which pharmacotherapy for obesity should be considered. Next slide, please. So let's look at the history of obesity drugs. And I can tell you I have been a skeptic for a very long time, until fairly recently, because we're actually starting to see some really good results with some medications. But the concerns have been effectiveness and side effects for at least 60 or 70 years. So none of us would do this now, but in the 1940s, believe it or not, people used to prescribe thyroid hormone for obesity. Now, as you can imagine, this was a bad idea, and it didn't work, first of all, number one. And people who had latent atrial fibrillation, which was harder to diagnose and detect in those days, often had symptoms all of a sudden when you gave them Synthroid, and there were sudden deaths associated with it. So it was a bad idea. So by the 1960s, amphetamines became the drugs of choice. Of course, they were associated with addiction, high blood pressure, and death. Elvis Presley, of course, was the most famous person who had abused these at that time, and things didn't work out so well for him. Next slide. So in 1992, we thought we had another miracle drug, that was fenfluramine, phentermine. And this was only on the market for 5 years, and it was pulled off the market, associated with primary pulmonary hypertension, and also associated with valvular abnormalities of the heart. So not only did the serotonin receptors in the brain get activated, but those on the heart valves as well, that caused damage that was irreversible. Then something that we thought was relatively safe, Accutrim or Dexatrim. Some of you might remember commercials for this on TV not that long ago. It was widely used for about 20 or 30 years, but eventually pulled off the market in 2000. because of the increased risk of stroke. Next slide. So, and going further, there were some promising drugs. I prescribed sibutramine to adolescents, and this was again a serotonergic drug associated with about 10 pounds of weight loss per year if somebody took it properly and followed a healthy diet, or it was roughly about $1,000 per year or $100 per pound. It was removed from the market in October 2010, and I remember putting some adolescents on this medication, and within a couple of days, their blood pressure would shoot up to sky-high levels. And when you stopped it, the blood pressure returned to normal. Rimonabant was a cannabinoid antagonist that was promising. It got a lot of press because it was the anti-marijuana type of a drug and associated with about, again, 10 to 12 pounds in a year. It was never approved here in the United States. It was approved for about a year in Europe, but there were so many suicides related to it because it caused depression that it was eventually pulled off the market. The next slide. So that is the history. And I think it's important to keep that history in mind because even though I'm much more open to prescribing medications now for weight loss, we do have some pretty strict parameters around it. So most of the patients that Jim and I see, they are monitored fairly often. The number of choices is fairly limited. I only prescribe drugs that I have a lot of experience with. And sometimes if they're not effective, we will consider tapering or stopping them. And you generally don't prescribe any medication for more than 6 months. So important physiological factors to consider when you're prescribing drugs are the three phenomena of satiety, satiation, and adaptive thermogenesis. So satiety is, I feel full in between meals. I just don't feel like eating. So some drugs have that effect, especially if they have a stimulant component. It's a little unnatural, to wake up in the morning, not feel like eating for lunch, and not feel like eating for dinner. Of course, you're going to lose weight, but it's not exactly the healthiest way to do it. So most of the modern drugs have some impact on satiety, but they also impact satiation. That is, I'm hungry, I'm starving, I'm going to start eating, but I get full really quickly, and I can't seem to finish my portions, okay? That, to me, is a more natural mechanism for weight loss because it doesn't disrupt our normal habits, doesn't require a whole rethink of things. And when you stop a medication that works primarily to satiation, there is, of course, the hope that your smaller portion sizes, smaller amounts will persist. Adaptive thermogenesis is another phenomenon that's very important for whether people lose weight through lifestyle changes or through medication. And that is, as you lose weight, your body adapts significantly. Your appetite is stimulated a great deal. And secondly, your metabolism slows. So people reach a natural plateau of weight loss. In some cases, medication can be helpful in overcoming that plateau. But that plateauing in weight loss, that adaptive thermogenesis is completely normal and to be expected. So next slide. So the guidance for when to use medications is really pretty sketchy. So the Endocrine Society developed these guidelines, and all it says, I'm not going to read the whole thing for you, is that consider medications in people who have a BMI of 30 or greater without comorbidities and 27 or greater with at least one serious comorbidity, which we've all read about many times. Well, that doesn't really help me because 2/3 of the American adult population has a BMI of over 27, and many of them have comorbidities of some kind or the other. And huge proportion of our patients, especially Medicaid patients here in Ohio, have obesity as well. But it doesn't really tell us what to prescribe or whom to prescribe it to. If we were to prescribe medications for all of these people, it would bankrupt the entire country because it would be millions and millions of people. So that's not helpful. Next slide. So curiously, because of that guideline, together with Dan Jones, who's at the Jackson Heart Study in Mississippi, we had proposed to our organization, which was the American Heart Association, that we develop a new guideline on pharmacotherapy. Now, unfortunately, they said, well, we've got this preventive medicine guideline coming out and we don't need one right now. But it was so difficult for them to come up with something related to pharmacotherapy that they didn't include it in the guidelines. So they don't have much guidance in the American Heart Association preventive cardiovascular guidelines at all about pharmacotherapy. And my proposal to the AHA is still out there, and we will probably start working on it in mid to late 2020. And this is not a bad thing, because when we finish, which year to about 15 months, we'll have more options available with pharmacotherapy, more experience, and we'll be able to put together a more decent guideline. So right now, what I'm trying to tell you is you don't have a lot of guidance besides what's available through experience and randomized trials as to the clinical choices for obesity. Next slide. So here are the options and the advantages and disadvantages. This is a very useful table, and hopefully you'll be able to use it in clinical practice. So phentermine, I'm not going to go through all of these in a lot of detail, but we'll go through a few details. Phentermine's been around since 1959. It's a stimulant medication. It's very inexpensive. Even the cash price is about $30 to $40 a month. There are low dose versions that people use. It's approved for up to 12 weeks at a time. Typically, after you have been taking it for 12 weeks, you need to have a little bit of a gap and take it again. It's by far the most commonly used obesity drug among patients in the United States. And many people use it intermittently. The low dose version can be used as well. There doesn't seem to be any difference between intermittent use and continuous use in terms of weight loss. And it does produce a significant amount of weight because you just don't feel hungry. Now, because of its side effects, its stimulant effects, its potential effect on pulse and blood pressure, people started to try to combine phentermine with other medications which are associated with weight loss. So topiramate phentermine, which is a combination drug known as glycemia, also causes about 10% of body weight loss in about a year. Very expensive because it's a patented drug and has some other concerns as well. Lorcaserin, which is actually kind of similar to fen, but it's an agonist for a different serotonergic receptor. Again, promotes satiety and to some extent satiation, extremely expensive. Some of you have probably heard about orlistat. This is the lipase inhibitor. It does not enter the body, so it is very, very safe. What it does is prevents fat absorption from the intestine. And it's been around about 20 years now, and there's a over-the-counter version called Ally. The problem with this is the side effects, and has a very, very high attrition rate. And the weight loss is not very, very significant, about 5 to 10 pounds per year. It's interestingly that the side effects, which are flatus, gas, bloating, leaky stool, are described in some of their brochures as socially undesirable side effects. So for a while, this was the only drug we could use in adolescents. And I thought to myself, these adolescents are socially isolated. Do we really want to give them socially undesirable side effects on top of that? So very, very uncommonly used, not really effective. Other combination drug, naltrexone, bupropion, known as Contrave, which we prescribe a fair bit with as well. Again, this is working both, but primarily through the satiation mechanism, which makes it very, very helpful. Now, the most effective medication that we have used is the GLP-1 glucagon-like peptide-1 agonist, liraglutide, which of course is a diabetes drug, as are all GLP-1 agonists, but associated with substantial weight loss. Probably in someone who's 300 pounds, you can expect 30 to 40 pounds over 6 months, which can be quite transformative for them. It works to some extent through satiation, but mostly it's a very mechanical effect. So a lot of these work on receptors in the brain. Liraglutide's primary effect is to slow gastric emptying. So you eat something, your stomach is full, and it only slowly enters the small intestine. And that means, of course, that you feel full most of the time. Now, the downside of that is if you start eating again, you may get sick. And the main side effect is nausea and vomiting. The other problem with it is it's extremely expensive. The cost is about $1,200 per month, which is very, very pricey. And so it's only covered by some plans. Next slide. So that having been said, coverage issues are significant. A lot of off-label use is also common. I use some of these medications off-label. They've been used for about 40, 50 years to promote weight loss. And you can get a decent weight loss. Now, as I said, we're going to talk about scenarios in which medication use is appropriate. But topiramate monotherapy over the course of 6 months is about 7 or 8 pounds, bupropion about 10 pounds, and metformin about 5 to 6 pounds of weight loss. Now, it doesn't sound like a lot, but in some circumstances, that can be very, very important to a patient, and it can be important to their health as well. Next slide. So this is a study done by Nicole Jana, who's actually on the National Academy of Medicine Obesity Committee, about coverage for obesity prevention and treatment services across the United States. So let's look at Ohio. Essentially, this is for Medicaid recipients and state health insurance, state employees. Now, state employees, I don't know why there's a lot of interest. I mean, there's quite a few of them, but we're mostly focused, of course, on Medicaid. And the bottom line is obesity medications are not covered in Ohio. And keep that in mind as you go forward. Mainly due to their cost. Very few states, as you can see, cover them. And even states like Michigan that does have some coverage, it's fairly limited. They do cover some. Bariatric surgery is covered. Nutrition counseling can be covered or uncovered depending upon the undetermined status means it's covered under some circumstances. I looked at this slide here on the bottom left here, and it's interesting that Mississippi and, well, Montana, but Mississippi, which has the highest rate of obesity in the United States and a very high proportion of Medicaid recipients, does not cover bariatric surgery. So that's very, very unfortunate. Next slide. So here are the scenarios. This is the important part. I don't want you to memorize all the options, the doses, the relative effectiveness. They're all about equally effective, except for the GLP-1 agonist liraglutide, which is more effective. But let's consider this, and I'm going to throw the question out to the group. Joanne is a 56-year-old woman with hypertension and obesity. She has tried numerous commercial programs, self-directed diets, and exercise programs to lose weight over the past 10 years. So despite these efforts, she's currently 5'5" tall, weighs 264 pounds. You've been providing lifestyle counseling for the past 3 months, both in person and by telephone. She's made some positive changes, has breakfast every day, walks up to an hour a day. She comes back after 3 months. She now weighs 269 pounds. So I'm going to throw this question out to you. A couple of questions. Would she be a good candidate for medication? And perhaps why is the more important question. Don't worry about which medicine to put on. Let's see who we have on here. Big crowd. Sunny? I think you're muted, Sunny.
Yeah, sorry.
Okay.
So she's tried counseling in the past and person and telephone. She's had a number of positive changes and she's like working towards it. I would like offer her something. I just like, because I have lack of experience using meds, I don't know what I would be offering.
Okay, so your answer essentially is you would offer her something. And that's what I would do as well. Can someone else tell me why you would do that? Anissa, are you on the line? I see your... Anissa?
I'm here.
Oh, I'm sorry, go ahead.
Oh, sorry. I watch these videos while I'm on the treadmill, so
Oh, okay.
I can put the video on if you want.
That's okay.
So I would start them on something because they might be becoming discouraged.
Yes.
If they're doing a lot of work and gaining weight.
Okay, so you guys are exactly on the right track. There is a danger in something like this, okay? So she is coming to you, she trusts you, she likes you, we've opened the door, we've provided counseling, she is trying, and guess what? For a reason, she hasn't lost weight. She's actually gained 5 pounds. Now, why did that happen? Maybe her efforts were not as robust as they needed to be. Maybe she overestimated her physical activity or underestimated her intake. Or maybe she's going through a little bit of adaptive thermogenesis. She lost weight, but then gained it back again quickly. Who knows what it is, but there is a danger. And next slide, Rick, and we'll talk about that in a second. Okay, so this is the quote from my book. It ends with some cases of children. These are adolescents. However, I think a lot of the principles are applicable to adults as well. So this is a scenario where two parents are coming in with their daughter, Katie, who is 11 years old, who is very, very overweight. And they are very frustrated. She is grabbing food from the cupboard. She's complaining about constantly being hungry. She's depleting her lunch account in school with junk food. She's eating everything in sight when she goes to her grandmother's. The grandmother's indulging her. And they say to their doctor, who happened to be me, we feel helpless. And the mom starts to cry. We don't know what to do. Now, I would not prescribe medication to an 11-year-old. So empowering the family was the approach here. But there is a point when people are trying to lose weight where there's the danger of them giving up. And so I wrote to them, Katie's weight had taken on a life of its own, something out of control against which they had battled frequently and lost. This poor lady, who's 56 years old, hasn't lost a pound, has gained a few pounds, comes back to you. If she looks incredibly discouraged, as Sunny and Anissa both indicated, there is a danger that she'll say, this weight thing, it's not happening for me. I give up. It is taking on a life of its own. It's something against I can't fight anymore. That's the point at which I would prescribe medication. Now, Sunny said, I'm not sure which one to prescribe. I can tell you, it's really going to depend a lot on insurance more than anything, okay? Our go-to medication is Contrave. You start with 1 tablet a day for the first week and then go to 1 tablet twice a day. The max dose is 2 tablets twice a day, but you don't even need to know that because you look at her insurance. If she has CareSource, if she has another Medicaid plan, consider one of the off-label possibilities just to give her a little boost. Now, it's not going to solve her weight problem, but you want to demonstrate to her that it's possible for her to lose weight. So she's 269. If she comes back at 267 a couple months ago, not a great result, but you can say, look, you did lose a couple of pounds. And I know the medication was helping a little, but it's probably you as well. So I want to make sure you understand it's possible for this to happen. Next slide. So this is another case. This is the kind of patient that Jim and I might consider prescribing medication to. Madison's a 37-year-old attorney and former college swimmer. She's gradually gained weight over the past 15 years and has grown increasingly concerned. A recent fasting lipid profile shows modestly elevated LDL cholesterol. Her father has obesity and a history of coronary heart disease. She's married and has a 9-year-old son. Husband and son are at a healthy weight. Madison's 5'7" and 173 pounds, BMI is 27.1, so not terribly overweight. Why might this be a good patient for medication treatment? It's because she has a very, very finite goal. She also can probably get there fairly quickly. She may have, and she is likely to pursue a healthy lifestyle in doing so. So medication may be able to get her there a little bit faster. So something to consider in someone like this who's high functioning, motivated, has a long, sort of this athletic history, has a compelling reason to lose weight, etc. Not the typical patient. We don't see a lot of people at this weight level, but we do see some. Next slide. And the third situation is Victor, 63 years old, has obesity. Now this gentleman is quite ill, 5'9", 334 pounds, has hypertension, dyslipidemia, type 2 diabetes, severe obstructive sleep apnea, osteoarthritis in both hips, coronary heart disease, 2 revascularization procedures in 4 years. He has a very good relationship with a bariatric surgeon. He's been asked to lose a minimum of 20 pounds prior to being considered for gastric bypass surgery. He has made some significant changes, he says. After 4 months, he's still 334 pounds. So sometimes bariatric programs will insist on some weight loss prior to surgery to show a commitment to lifestyle changes, because you do have to be committed to dietary changes afterwards. However, the ASMBS, the American Society for Metabolic and Bariatric Surgery, has taken a position against that, saying this is not appropriate. Now, that's controversial, and I don't want to get into that controversy so much. This might be a guy for whom medication would be appropriate, so he can demonstrate some sort of weight loss. Even taking medication is a sort of commitment. requires changes to his lifestyle as well. So another scenario to consider. Okay, next slide. Okay, we are going to give you a couple minutes for questions and move on to our cases this morning.
I have a question. So like I have sent some of my patients that do go to bariatrics, and I often see them put on Victoza right away. Is that something that you would also do first line, just as like someone that you'd be following in your own clinic?
So great question. So Sunny's question is about Victoza. Victoza is the same thing as liraglutide. It's Saxenda. It's just a different brand that's approved for diabetes only. We have a rule, Jim and I have a rule that at the first visit, we don't prescribe medications at their initial visit. I think that's generally a good rule. A lot of people seeking help for weight management are seeking quick solutions. They come in, say, I just want this medication, and then I don't see them again. I don't know what's going on, whether they're losing weight, gaining weight, having side effects. And you may have had the same experience. So usually it's the second or third visit we will consider it. Is liraglutide a good option? Yes, it is. And you can titrate it just the same way as you can the obesity approved version, which is Saxenda. Liraglutide is also very expensive. Sometimes you can get covered for Medicaid recipients. It depends on whether they've been on other diabetes medications as well. Now, I will tell you, if they don't have diabetes, you're not going to get liraglutide approved. So the bariatric surgeons may be doing this, but they're doing that for their diabetic patients mostly. Okay, any other questions?
I have one more question. So
Yes.
for off-label medications like topiramate and bupropion, is the weight loss dose dependent?
So the question that Kriti has is about topiramate and bupropion. Is there for off-label, is there a dose-dependent weight loss? Yes, there is. And I can tell you, you don't get a lot of weight loss unless you start using a fairly high dose. So for example, and this is not those two medications, metformin, you don't get a lot of weight loss unless you use 2,000 milligrams a day. Topiramate, really you start to see it about 100 or so. But if you go beyond 100, you start to get side effects. You get paresthesia, this dissociation associated with it. So typically for me, 100 is the starting and the maintenance dose. Bupropion, 150, you will get some improvement. Now, whether that is through promoting satiety or satiation or just because their mood is better, I don't know. But they do tend to be more energetic and stuff. And you can go up to 300 with bupropion. So I'd say 100 for topiramate, 150 for bupropion, and you can go up a little on bupropion, but I wouldn't do anything else.
Thank you.
I have a question too.
Yes, go ahead.
For the patient who you said had a BMI of 27, would you start them on the same, like would you choose like topiramate or bupropion, or what do you do for people who have a normal BMI?
Okay, so her BMI is in the overweight range, but it's relatively low. So again, Anissa, so I think insurance issues will determine that. My go-to, because of its minimal side effects, its safety profile overall, and the weight loss, is the Contrave. It's bupropion naltrexone. If she doesn't have coverage for it, I would just put her on bupropion.
Okay.
Okay, Shannon, I think we can go to our cases.
And I think it gets to some of the things, even what Goutham had talked about earlier in some of our sessions about with the magnitude of weight, gaining 100 pounds. If you want to kind of mentally quantify how much food 100 pounds would really lead to, this kind of gets into some abnormal physiologic responses. Because gaining 100 pounds in a short period of time, especially if they are doing some of these behavioral things, so it'll require more than the normal kind of behavior change, which is why I think the underlying depression issues fall in there, and kind of addressing both the social determinants of health, the income capabilities, as well as the emotional piece. that's why I do think Adam's comments about that engagement, especially I'm part of a running and walking group that's basically kind of an all paces welcome, and that's the kind of support structure it provides. That those things can kind of do that. The only thing as far as kind of the dietary side is we have this assumption that if we get somebody to stop eating fast food and they cook for themselves at home, it becomes better. But if you, instead of eating fried chicken out, you eat fried chicken at home, it's that kind of no major net gain, except for they got to cook it themselves. But I like the fact that you've had the cooking classes and had the dietitian available so they can kind of help address that. But with the lack of coverage, we know that that ends up being a barrier. So I think that those other underlying issues are going to be the primary thing that'll help. The diet can help, but the diet has to fit within all that broader context of issues.
Thank you, Christine. So just to tag on to Chris's comments, I said, I think a couple of weeks ago, it'd be nice if there was a calculator that showed how much you're actually eating to maintain your weight. And there was one that I found, and I actually plugged in this woman's numbers, assuming she's completely sedentary. She's young. I think you said 28 years old, plugged in her height, weight, female, and it's close to at least 4,000 calories per day. That she is likely consumed. Now, there's going to be some variation. Everyone has a different gut microbiome. Everyone has a different physiology. So maybe 4,100, maybe 39, but that's a lot of food. And thinking about this from the primary care standpoint, in a completely different context, when you have someone who's smoking 4 packs of cigarettes per day, that means they're smoking, if you calculate it, they're getting up in the middle of the night and smoking several cigarettes. They're smoking almost all the time. So when you get to that point where you're eating 4,000, 5,000, 6,000 calories per day, something is always almost being eaten. So, so that's very, very abnormal physiologically and psychologically as well. Jim, did you have any additional comments about her?
Yeah, just, her mental health issues are really important in this, and it's great that she's getting counseling and she's on bupropion. But it sounds like she's experiencing depression and possibly PTSD because of the experiences she had at home growing up. And so there can be a great deal of shame associated with her body habitus. And also, she lives alone. So she's 28 years old and she's really kind of setting patterns for her adult life. And so I completely agree with Adam and Chris about the social isolation component, and a lot of unhealthy eating takes place with loneliness and shame. And so getting her out and involved in some healthy activities, encouraging that, the walking clubs and things like that, and other activities where she's involved with other people in a healthy way, that can really make a difference, I think, in both her mood, her ability to relate with others in a healthy way without feeling shameful. So her mental health counselor can be really helpful with that. And I don't know if you have any opportunity to interact with that counselor about her weight issues, but attention to these issues would be really important. The other thing would be potentially to take a little focus off the weight and just focus on her blood pressure too, as outcome measures for her that you're working with her on. And weight would be kind of the one strategy for getting there, but it kind of takes the focus off of weight as the sole problem, and focusing just on other things like outcomes, health outcomes like blood pressure. That's all I have.
Thank you, Jim. I think we do need to move on to our second case, please.
The one thing I think we've hit on a lot of those things when you are addressing the kind of resistance to make change, and you're kind of up against a brick wall. But I think you've got some opportunities that she's presented. The fact that it's important for her family to eat healthy, but she's not doing it herself. And some of the reframing around, clearly family then becomes important enough to provide a separate meal for them instead of herself, but then the behavior that she's doing is eating what she wants. So if we can capitalize on the family importance, now it's if she's clearly the provider of healthy food in this situation, she has an impact on the overall family structure and not just her own health. So the greater she impacts her own health negatively, the more it's going to impact her role in working with her family. So how can we use that maybe together so that's not a focus on her weight and maybe not a focus on her health status per se, but it's a focus on her role in the family and that social duty she's playing as opposed to being about her. And maybe that helps with some of those changes. Because even if she just has dinner with them, that's a significant impact on her lifestyle behavior. To not eat the fatty food and to eat the healthy food she's cooking for them, that's a huge win, which is ultimately a social change and not a health behavior change.
Thank you, Chris. And I just want to echo Chris and Adam's comments that sometimes that seeming lack of motivation is actually more ambivalence about changing behavior or a lack of self-efficacy. And so it's obvious this woman has some knowledge of what healthy food is if she's preparing something healthier for her family. So she understands the implications of it. So that might be a bit of an opening as well. All right, very interesting case, both of them actually. So I'm going to turn things back to Shannon to close up.
Thanks, Dr. Rao. Thanks, everyone. You have received a post-clinic survey in your email. Please complete the survey for our feedback after this clinic. Next slide. We still have registration open for the spring 2020 tele-echo clinic, reducing the burden of hypertension, that starts January 16th for 12 weeks, Thursdays 8 to 9. If you click on the link there, it will take you to our information page. There's a flyer. If you would share that with your colleagues, we would be most appreciative. And if you haven't taken this course, or even if you have, there are quite a few new things that we're bringing to the next curriculum. Next slide. You have the opportunity to watch any of our previous echo clinics at our website. You just have to register. And next slide. And finally, I've been saying this, but you will receive 2 separate emails regarding exit and CME surveys. One you will receive from myevaluations.com. If you wish to claim CME credits, you can begin the process now and register with My Evaluations, and then you'll receive your link at the completion of the ECHO series. And then finally, we'll send an exit survey for our own evaluation purposes. And reminding you, there's no clinic next week because we'll all be eating Thanksgiving dinner. And the week after that is December 5th. We'll have weight management partnerships and collaboration.